Hi there. All right, so this PowerPoint is kind of combining some neuro content and some musculoskeletal content. I've gone through and picked out the pertinent parts of the PowerPoint. I'll post those. Ooh, that's a lot of P's. I'll post those as soon as I've finished recording this. But I want to go through the PowerPoint, then I want to go through the chapter and point out exactly what I want you guys to focus on. All right, some anatomic differences in kids versus adults, and this is dealing with both neuromuscular and musculoskeletal. Their motor development begins at birth and it goes in a predictable sequence, and what that means is that gross motor development goes from kind of the center out, and fine motor development comes later. So you'll see that develop after the gross motor skills kind of develop, and then you'll see the fine, like the pincer grasp and those kind of motor development. You'll see that happen. They can curl their toes, things like that. They can move everything at birth. Their spinal cord is a little bit more flexible than the adult. You don't see as many spinal cord injuries in kids as you do adults for that reason. And these 3 points I want you to make sure you remember, okay? Their skeleton is not completely ossified, so their growth plates aren't closed, and we'll talk about growth plates here in a minute, until adolescence. So there's a hormonal thing that happens in adolescence that causes those growth plates to close and the skull to completely ossify. Therefore, it's harder to break a bone like in an infant. So when you see rib fractures in an infant, that was a lot of force applied to those ribs in order to break it, because they're pretty cartilaginous and they're pretty flexible. So just kind of remember that when you're assessing a patient and you see an infant with a rib fracture. The growth of the bones occurs primarily at the growth plates at the end of the long bones, and we'll talk about growth plate injuries. There's a good picture in the book about a growth plate. And then kids' bones heal a little bit faster than adults because they're so vascular. All right, some things you want to focus on when you're taking care of a kiddo with a neuromuscular or musculoskeletal disorder. You want to maximize their mobility, okay, however that looks. You want to do range of motion exercises if they're bedridden. Make sure that they don't get foot drop if they're like a cerebral palsy kid. So, you want to do your range of motion. Make sure that they get up. Like kids with scoliosis that have spinal fusions, getting them up is a big priority, because you want to make sure that they stay as mobile as they can. Promote adequate nutrition for healing, lots of calcium. Effective elimination, especially if they're bedridden or if they're in traction, and especially if they're on pain medication. You always want to make sure that you assess bowel sounds, because pain medication can make you constipated if it's the narcotic kind. Of course, promote skin integrity. If they have a cast, you always want to make sure that you assess under the cast. Make sure it's not rubbing. If they have had surgery, you always want to make sure that you assess your surgical site. Pin care, if they are, and we'll talk about traction later on, if they have pins, you always want to make sure that there's no infection at the pin site. Maximize self-care. Of course, you always want to promote independence in all your patients. Development, if they are a femur fracture and they're in the hospital for a long period of time, then they could get a little regressive, and you want to make sure that they continue on their normal developmental path. Preventing injury, making sure that they can walk safely on crutches, really important. And then, of course, the good old education to the child and the family. All right, some lab orders that you might see for these kind of disorders. The biggest thing, especially with trauma, is going to be x-rays, CTs, MRIs. Those are the things that you're going to see most likely when you have a child with some sort of musculoskeletal issue. if it's more serious or if they're suspecting some sort of congenital issue, you might see the others like an EMG or genetic testing. But for the most part, you're going to see X-rays, CTs, X-rays, MRIs. All right, there's a couple different types that we're going to be talking about. Congenital is some sort of structure abnormality. Spina bifida falls into this category. Scoliosis falls into this category. We'll get to that point. Those are towards the end. Acquired musculoskeletal trauma, your fractures, spinal cord injuries, anything. We're not going to talk about Guillain-Barré, but that's another neuromuscular issue that's caused by a viral infection. So, all right, what are you looking for when you are assessing these children? Of course, you're going to look, inspect, and observe. You're going to look at their motor function. You're going to look at their sensory function and their reflexes, especially distal, if it's an injury, especially distal to the injury. We've got a lot of forearm fractures, so you have to make sure that they can feel you touching their fingers. They can move their fingers. Make sure that everything distal to the injury is intact because you're looking for nerve damage. So if you have a fracture that's impinging on a nerve, you're going to see sensory, motor, reflexy type deficits distal to the injury. Palpation, you want to make sure that you check their muscle strength, their muscle tone, and then you can, going back to observation, of course, if you see any obvious deformities, those are all important too. And then listening to their lungs, listening to their belly, making sure that, nothing's going on there. If they're immobile for a long time, pneumonia is a complication. Constipation is a complication. Pressure ulcers. So those are all things that you want to look for. All right, some examples of congenital neuromuscular disorders. Neural tube defects, spina bifida is the one that you're going to see the most. That's what we're going to talk about the most. And those babies are born with, a lot of times they're born with a myelomeningocele. We're going to touch on that. There's a good picture in the book of a myelomeningocele, and we're going to talk about what to do, how you fix that, etc. And the complication or the signs and symptoms, manifestations of spina bifida. We're not going to talk about muscular dystrophy or spinal muscular atrophy. Those are fairly uncommon. I don't know that I've ever seen a spinal muscular atrophy. I've seen a muscular dystrophy, a couple of kiddos, but you just don't see it very often. You can read up on it in your spare time. All right, some acquired neuromuscular disorders, CP or cerebral palsy. We'll spend a little bit of time on that. There's a wide range of things that can cause that. Spinal cord injury, botulism toxicity, a stroke, of course. If you have a sickle cell child, you have to think about stroke. Intraventricular hemorrhage, if you have a preemie, they are really susceptible to those just because of their preeminess. Viral bacterial infections or post-viral syndromes such as Guillain-Barré. And again, I'm not going to spend a lot of time, probably or any time. I would say it's fairly uncommon. I've seen it probably 3 or 4 times. And just to kind of give you an idea of what it is, it's a progressive neuromuscular kind of paralysis that varies in severity. A lot of times they present, they're clumsy, they can't walk. I've had one present with not being able to hear, so it affects nerves differently. The neuromuscular part of it is, they have weakness in their legs, and it's kind of progressive. It kind of goes from the bottom up, so it's a strange little post-viral syndrome. Neurological compromise because of compartment syndrome. If you have a fracture, we're going to talk a little bit about compartment syndrome and what to do and why it's an emergency. And then some autoimmune disorders cause some acquired neuromuscular disorders too. All right, let's talk about cerebral palsy. Okay, it is a term, a broad term, to describe a range of very nonspecific symptoms. That is a very good definition because it can be anywhere from just a little limp, or it can be full-on total care, developmentally devastated, immobile child. It's the most common motor disorder in childhood. You'll take care of a lot of patients that have CP because they have other things that go on with it. They're more prone to infections if they are, the totally developmentally devastated full care patient, because they're immobile. They get pneumonia a lot. They aspirate. So it can be pretty devastating. Of course, higher in preemie babies, and that's because one of the causes, and in the text when we go over the chapter, I'm going to show you the big long list of things that might cause cerebral palsy. One of the things is if they're preemie, or if there is a pre-birth insult to the brain, they can be born with CP. I'll let you read through the signs and symptoms and the complications there. All right, nurses caring for a child with a neuromuscular disorder knows that what is the most common movement disorder, and we just said that, cerebral palsy. All right, some structural disorders that are congenital. DD, developmental dysplasia of the hip, DDH, is probably the most common one that I've seen. When we get to the text, there's a really good picture of what it looks like. It is where the head of the femur slips in and out of the hip joint. My daughter had this whenever she was born. She was breech, and that is a risk factor. And so her hips popped in and out when she was born. And there's a specific test that you can do for that, and you'll see probably when you get to your OB course, them doing the Barlow's and the Ortolani test to look for DDH. So we'll talk about that in a second. Pectus excavatum and carinatum. Okay, pigeon chest. When you see a child with his, okay, so if you're doing a respiratory assessment and you look at this child's chest and it is way sunken in the middle, that's a pectus excavatum. Okay, normal. Abnormal, but normal for that child. That is not a retraction, okay? Unless mom says, oh yeah, it's worse than normal. But that is a kind of a variation of the sternum there. And it can also come out, like bulge out. That's carinatum. So you may see some sort of abnormality with the chest wall there. That's what those are talking about. Polydactyly is an extra digit. Took care of a little girl the other day that had 6 fingers. And you've heard about Ernest Hemingway's six-toed cats. That's polydactyly. Okay, Osteogenesis Imperfecta. Very real. A lot of times confused with child abuse because these kids present with fractures over and over and over again for no real traumatic reason. They can bump something and have a fracture. Brittle bone disease is what it is. All right, scoliosis is another. When you guys get out into community, you may be, if you're in a school district, you may be doing scoliosis screenings. The schools do those still. Scoliosis is defined as a lateral curvature of the spine greater than 10 degrees. They don't really start treating it or getting concerned till it's about 30. I think 30 degrees. The book says 20 to 40. Out in practice, we use the 30 degree. At 30 degrees, if the curvature was at least that, then we brace them. So that's scoliosis. One of the things that you can pick up on, or a couple of things if you can pick up on to think, oh, maybe that child has scoliosis, is like if their hem is uneven, if they have a dress on or a skirt on and their hem is uneven. Or we had a patient when I was out in private practice present. She came in, she was a teenager, and she said, One of my breasts are bigger than the other. And so we got to looking, and she had not a lateral curvature, but she had like a rotation in her spine that was deemed scoliosis, and that's why one side of her chest came forward a little bit farther. And there's some pictures. Those are pretty severe. That's much more than 30 degrees, I think. All right, some things you're going to assess in a kid when they present and might make you think neurological disorder. Changes in gait, that's the biggie. They get clumsy. If they just don't feel like, or they won't keep up with their peers. Of course, trauma, muscle tone weakness. You want to do a good neuro assessment, and you also want to get a good history of their milestones. Did they walk at the right time? Did they crawl at the right time? Because you can see, like, muscular dystrophy may not be picked up at birth, but if they don't progress in their milestones, which is another reason why milestones are very important, if they're not progressing, then you might start to think about something like this. You can also get, or you can also see Spina Bifida Occulta, and what that is, they don't have a myelomeningocele. They don't really present with any neuromuscular symptoms until they are hard to potty train or until they don't walk. And then you start to look for other things. So that's another reason why developmental milestones are very, very, very important to know. All right, so let's talk about acquired musculoskeletal disorders. These are your sprains, strains, fractures. I don't know, it lists scoliosis here, but that's kind of, there's nothing you can really do to get scoliosis. So if it's, if your spine's going to curve, it's going to curve. So I think it could go in both categories. Not test material. Don't worry about that. Slipped capital femoral epiphysis, or a Skippy. That's what we call it, a Skippy. A Skippy is where it's usually seen in overweight kids. Not always, but most of the time in overweight kids. And it's where the top of the femur pops out or comes off. It's where it splits apart. The head of the femur splits apart from the femur itself. It's kind of a surgical emergency. So if you have a child, and the way that they're going to present, and it's in the text, is they're going to present with a limp usually, and maybe a little turnout of the leg. X-ray it. They get a frog leg X-ray, and if it's the slipped growth plate there, then they don't walk on that. There is no more pressure put on that. You are bed rest until it's surgically fixed. Nursemaids Elbow. This is where the radial head pops out. It's at the elbow. There's a maneuver you can do. I've actually reduced a couple of these to reduce the nursemaid's elbow. It's not a fracture. These children present with, they won't use that arm for nothing. You can hand them a popsicle and they'll grab it with the other arm. It is very obvious when they won't use that arm. And that's how, if we see this child present to the ER, say, and they won't use that arm, and we use this little maneuver to fix it back in place, then we hand them, occupy their other hand, hand them something, and they'll use the arm. So that's kind of how you tell that you fixed it. The other things you probably won't see very often. All right, some concerns with fractures. Growth plate concern. So if you fracture a long bone at the growth plate, it can damage that growth plate, and it can lead to shortening of the limbs or kind of like retarded growth of that arm. It may be a little deformed. So that's always a big concern. If you hear, is it fractured at the growth plate? No is a good answer. We're going to talk about cast and splints. The difference, a splint is temporary. A cast is more, it's not permanent, but it's the longer of the two. A lot of times with a fracture, they'll put a splint on to kind of make sure that the swelling, let it swell as much as it's going to. Then they'll cast it if it's a fracture. Compartment syndrome. Compartment syndrome is a very big deal. Compartment syndrome occurs when you have a limb that's casted and the swelling just gets so big that it compresses neurovascular integrity to that limb. So it's a big deal. Pain, increasing pain that's not relieved by pain medication. You always want to look at your digits that are outside the cast. Make sure the capillary refill's good. Make sure that they're warm. So compartment syndrome is a big deal. It is call the doctor, get the cast off. Sometimes they even have to do a fasciotomy, which is split the skin open and let the swelling on the inside of the tissues happen. So big deal, compartment syndrome. Some interventions for preventing complications of immobility. Make sure you turn and reposition, not unlike adults, because they can get skin breakdown too. Keep the skin clean and dry, of course. Range of motion, we talked about that. Lots of fluids. You want these kids to stay hydrated, and you want to make sure that they keep their nutrition up. Cough and deep breathe because you don't want to get pneumonia. All right, we're going to talk briefly about spinal cord injury. Football injuries, diving injuries, those are biggies. If you get a child that comes in with some sort of traumatic situation, they'll usually be in a C-collar, okay? And you don't take that C-collar off, okay? The collar around their neck. That is a physician's call. And they have to be cleared. They're usually on a backboard and have a C-collar. They have to be cleared in order to get off that backboard and in order to get out of that C-collar. Now that may take just a physical examination by a doctor, or that may take an x-ray, but whatever it takes, you do not take that off. If you need to turn, if it's a trauma and you need to turn and look at the back of the child, then this is like a 3-person turn. Somebody holds what we call C-spine, okay? Somebody holds that head, and you rotate that head with the body if you have to turn it over and look at the back. So make sure you maintain your spinal alignment, because you don't want to risk anything. If there's some sort of tissue integrity breach in there, you don't want to risk, paralyzing these kids. So you're going to assess numbness, tingling, weakness, all of that in their feet and their arms. Inability to breathe, it's a high C-spine injury. That's a bad thing. Things to prevent, teaching topics to prevent spinal cord injury. Of course, vehicular safety, seatbelts, bicycle helmets, diving, water safety, all of those things. Those are a great, that's a great slide you might write those things down. All right, so now I want to go to the chapter, okay, because there's some important stuff in the chapter that's really not in the PowerPoint, okay. All right, we talked about variations. We talked about, okay, so here's a picture of bone healing, okay, and remember I said kids' bones heal faster because they have a big, strong blood supply. That is true. And there's the growth plate. Okay? If the fracture is low or goes through the growth plate like that, then it can cause some issues later on in life. It doesn't always, but it can. Okay? So remember that growth plate picture. Here's a couple of pictures with some knock-kneed and some bow-leggedness. They have fancy names. You might see these in kids too. I'm not going to test you on them, but it might, you might see them. Your neighbor is going to come to you and say, hey, what's wrong with my little girl's knees? So you can throw out the big word, genovalgum, or knock-knees. There's a little key, it's kind of a no-brainer. We just talked about it. Fractures are really rare in kids younger than 1 year of age because of their elasticity and their cartilaginousness of the bone. So anybody that presents under 1 year old, if they don't have a really good story and you're suspicious, it might warrant some investigation. All right, cast. There is a great section on cast care. Okay, they now make waterproof cast, okay? So it's called Gore-Tex, and You can swim in them. That used to be the big thing. You know, kids would break their arms in the summer and then they couldn't swim all summer. Well, somebody got smart and invented a waterproof cast. How long did that take? Forever. Crazy. All right, so here's this is a good chart. The one column that I want you to make sure that you look at is the nursing implications. Okay, talks about casting, talks about checking for neurovascular compromise, a key point. Okay, teach parents to look at the fingers, and if their fingers are blue and cold, then something's wrong. Okay, same thing with the splint. All right, it does talk a little bit, and when we talk about sprains and strains, about cold therapy, because a lot of people put ice on and leave it on. 20 to 30 minutes, then take it off an hour, then on 20 minutes, take it off an hour. You don't want to risk any kind of, you can actually get frostbite by, you know, applying those ice packs. Okay. Talks about traction, and we're going to hit traction in a second. So this is a good little table to pay attention to. As far as pain medications, you know, usually you're going to get Tylenol and Motrin. If it's a femur fracture, something bigger like that, you might get a narcotic. Again, if you get a narcotic, these are the things to assess for. Okay, make sure constipation, make sure you've got a reversal agent there. But most of the time with the musculoskeletal injury, you're going to see Tylenol and Motrin. Here's a good example of some casts. There's a short arm cast, long arm cast, and all of these are injury dependent. So it just depends on what your injury is as to what kind of cast you get. Femur fractures, they get the biggies. Pelvic fractures, if they're bad enough. All right, traction. This lists the information about traction. However, the chart is over here. See if we can click to the chart, or we've got to manipulate our way to the chart. We can do that. All right, going along, going along. All right, this is a good section to pay attention to too. Your nursing diagnosis, your interventions are going to be based on nursing diagnosis. Now at the end of the chapter, like with every chapter, there's a care plan. And I want you to pay attention to the care plan because it talks about what you're going to assess, what you're going to do, what you're going to teach, etc. Okay? All right, this is what I want you to see. How to take care of a kid with a cast. In addition to the traction, I'm getting to that one too. All right, some things to look for, okay? And these are things that are going to indicate maybe a possibility of a compartment syndrome coming on, okay? Increased pain, increased edema, pale or blue color, skin coolness. Assessment is very, very, very important post-casting. Now, if they get a cast and they go home, you're not going to be there to assess. So you've got to do teaching with the parents on this section as well. All right, there's a little guy on crutches. Home cast care. There you go. Big, long list of things to teach. Cast removal, that's usually done in the office. Okay, here's our traction. They've divided it up into skin traction and skeletal traction, and you need to know what is skin traction and what is skeletal traction, okay? So the big ones that you're gonna see, you're gonna see 90-90 traction, usually in a femur fracture in the hospital. Those guys are there usually about 6 weeks, okay? So 90-90 traction, I'm gonna let you read through the skin traction. The only difference is skin is there's no break in the skin. So you're pulling on the skin or the outside in order to maintain the traction. Okay, Russell traction you'll see a lot, Buck's traction you'll see a lot. These both involve weights, okay, and the weights are prescribed by the doctors. Do not mess with the weights, okay? Do not release those unless you have a doctor's order, okay? The one that you'll see with a femur fracture is the skeletal traction is the 90-90. And these kids they have a trapeze above their bed to pull up on. They have this big setup on their bed. And it's great. I know at Cook's, they'll take them down to the atrium in their bed with their big traction on top because they are there for 6 weeks. And you have to think about things like growth and development and, just, keeping them sane for being in there 6 weeks. But skeletal traction, I don't know if you can see it right here, but they have pins and they go into the actual bone. So skeletal traction goes into the bone. There's pin care involved. I want you to read up on pin care, what things to look for. Osteomyelitis is a huge risk, and that's just infection of the bone because you have a breach in that bone, because you have a pin in it. Cervical traction and a halo traction. Here's a halo traction right here. If you have a spinal cord fracture, they want to keep your spinal cord as straight as they can. So you'll have pins. This looks horrible. You'll have pins into your skull, and it puts the halo on and maintains that alignment of the spinal cord. Okay? So know your tractions. You'll be the smart one on the unit. Preventing complications. Constipation is a complication. Pneumonia is a complication. All part of the care plan. Okay. All right. External fixation. You'll see that's the halo traction. Okay. All right. Neural tube defects. This talks about spina bifida. Okay. There's your different levels of spina bifida. I want to get to the myelin or the meningocele. Pay special attention. Read the section on spina bifida. Okay. Here's a myelomeningocele, and these kids are born with their spinal cord outside in this sac. Okay. Some important things to remember. You got to keep that sac moist. Okay. You cannot let it dry out. You've got to keep the child on their belly. He's already got some hydrocephalus. You can see from the obstruction of the spinal fluid in the myelin meningocele. These are repaired surgically, okay? So think about what you want to do. You want to keep it from getting infected pre-surgical, and they're repaired pretty quickly. You want to keep them from getting infected, so your diaper, you're going to make everything kind of flow away from that. So laying this baby on his belly is what you got to do. I know it's not what we talked about, because baby's back to sleep, but in this case you got to do that. Also, once they're surgically repaired, you have to figure out a way to get the dirty, the stool and the urine away from the incision site. So just know that's good. Those are some good nursing interventions that you might run across. Okay, so I want you to read through the section on spina bifida. Lots of good information. Spina bifida patients, again, varying degrees of spina bifida. They can have bladder control or maybe not have bladder control. If they don't have bladder control, then they are self-cathers. Okay, and here's some teaching guidelines for intermittent catheterization. UTIs are very, very prevalent in spina bifida patients because of their necessity to self-cath if they don't have bladder control. Another thing that you will see with spina bifida patients is latex allergy. Let me get to the paragraph on latex allergy. There it is. Only latex-free, and most of our children's hospitals are latex-free anyway. Only latex-free supplies for these kids. They are exposed so many times for their surgeries and their catheterizations that they develop a sensitivity to latex. Most all of them have it. So make sure that you're aware of that. Lots of education to do there. Okay, here's a good picture of the Pectus Excavatum. And can you see how that might be confused with the retraction? Okay. Therapeutic management, there's really nothing to do for it. Okay. There's a little extra toe. And again, unless they are, sometimes they surgically remove it, sometimes they don't. There's a metatarsus adductus, and that's just kind of a deviation of the forefoot there. A lot of times they don't fix those. If they're severe enough, like with clubfoot, they do some serial casting. They apply a cast, let them kind of turn because their bones are so flexible. Then they'll apply another cast. And sometimes it's like a weekly thing. Sometimes it's a monthly thing. Okay. All right, Osteogenesis Imperfecta. Here's the classifications. You don't need to know the classifications, but you do need to know some teaching tips for Osteogenesis Imperfecta. These kids are fragile little China dolls. So no contact sports whatsoever, of course. But even as a baby, you don't want to push and swing them around, and you don't want to do that anyway. That causes Nursemaids Elbow. But be aware of the teaching implications. All right, here's DDH, developmental dysplasia of the hip. Now, what I want to show you with DDH, two things. I want to show you the Barlow and the Ortolani. All right, so the way I remember this, you'll see the nursery people, probably the nurse practitioner or the physician doing this little test when you go to OB. The Ortolani, if you remember, Ortolani is out and Barlow is back. So what they do is they take their little thighs and they bend them out, and if they feel like a clunk, sometimes you can hear it, but if they feel it, then that's positive, okay? And then they bring them back. Barlow is back. And same thing, okay? So Ortolani is out, Barlow is back. Then if they feel that clunk, they'll do an ultrasound. And treatment for this looks so primitive, but in this picture, I hate it that it doesn't show the whole picture. Let's see if we can get it to show the whole picture. Oh, we can't. Darn it. Okay, if you have a printed version of the text, it's in there, but I don't see it in here. Oh. Okay, so it keeps them frog-legged, okay? You frog-leg their knees, okay? And you hook this, and this is just with Velcro. It looks very primitive, and sometimes they have to wear it like up to 3 months. But the physician wants to keep them on 24 hours a day. You can take it off and you can bathe them, and then you put it back on. You can change their diaper when it's on. I'm gonna find a better picture of a Pavlik harness and post that, because I want you to see how it is at the bottom. It's pretty funky looking. It makes them like a little football. So you put this on over their clothes. Again, assess for skin integrity, because it is Velcro, and it's not they've made it a little softer, as far as the material inside, but it still can rub blisters on their skin. So make sure you do a good skin assessment. All right, and there's some teaching guidelines, okay, for kids in Pavlik harnesses. All right, torticollis, you may see this in infants if they are in utero in one position for a while. Then those muscles in their neck get kind of tight. Easily fixable, parent teaching musculoskeletal manipulation. So they just basically move their head around, make them look the other way, okay? Pretty common. All right, and muscular dystrophy, I said we're not going to talk about. If you would like to know more information about that, please read that. All right, spinal muscular atrophy, again, we're not going to touch on that. That means it's not testable, okay? Here's some more information on cerebral palsy. And remember I said there's a long list of causes. Box 22-1 gives you a long list of causes, okay? Lots of different things can cause it. All right. And most of the time it's a movement disorder or a movement manifestation that you're going to see. But a lot of times you'll see the developmental devastation too. Physical and occupational speech therapy, really important. I want you to read through the section on cerebral palsy. I want you to know about that. Okay. Respiratory assessment, very big. Baclofen and pump, if they have spasticity, put this up here a little bit better. If they have spasticity, then they may have a baclofen pump to kind of reduce that spasticity. That's a big deal with cerebral palsy kids. So here's some information on teaching parents about a baclofen pump. Nutrition is big because you want them to maintain their skin integrity, maintain their cardiovascular health, etc. All right, rickets. I have never seen a case of rickets. So if you'd like to know more about rickets, there's you some good reading information. Here's the information on a Skippy and how to manage that. It's nursing management. Again, do not get these kids up, okay? Do not get them up if they have been diagnosed with a Skippy. All right, and then scoliosis. Here are some braces that they use for scoliosis. Again, they brace about 30 degrees. So, all right, here's the pictures that we saw again. Here's log rolling after a spinal fusion. If the case of scoliosis is severe enough, then they do a spinal fusion. I mean, I've seen kids with like a 50-degree curvature, and they have to fix those. So they do a spinal fusion, big surgery. So post-surgical, again, you assess for constipation, mobility, neuromuscular. Those are all things that you assess for post-operatively. We talked about spinal cord injury. We talked about fracture. This lists the types of fractures. No, you don't have to know the types of fractures, but if you're ever going to work out in the community where you see a lot of fractures, it might be nice to know what a green stick fracture is or what a buckle fracture is. Buckle fractures are the most common forearm fractures. Complete fracture, there you go, the bone breaks in half. Open fracture is not on here, but an open fracture is where the fracture comes through the skin. It's a big deal. It's surgically repaired. There's an external fixator for a tibia fracture. Looks painful. Can you see where the potential for infection might be? Yuccola. All right. Talks about assessing after, a cast application after a splint. All right, sprains and strains. All right, I think this is the last section that we're going to talk about. Sprains and strains are probably the most common musculoskeletal injury. They're soft tissue injuries. Sometimes they're called overuse injuries. They sometimes take as long to heal as a bone. So kiddo comes in, felt my ankle pop, they do an x-ray, no fracture, they put them in a boot or they put them in a little ankle brace, and it can hurt for a while. Okay, a lot of times they put them on crutches, even for a sprain or a strain. So keep that in mind if you have a child or a patient that said, I hurt my ankle a while back 3 weeks ago and it's still hurting. Yeah, it could. And the treatment for that is rice. You rest it. You apply cold packs, like we said, 20 to 30 minutes. Take them off for an hour, 20 to 30 minutes. After the first couple of days, the ice probably won't do much good. So just keep that information in your parent's head. Again, parent teaching. Compression, put an ACE wrap on it and keep it above the level of the heart. That's what RICE stands for. Rest, ice, compression, elevation. All right. Radial head sublux is the nursemaids elbow that we talked about. Nursing management is you got to put it back in. And it is like immediate. They will start to use it again. So, all right, the last thing I want to tell you about is your care plan. Please go through that, read that. It has a lot of good nursing interventions. And like I've told a couple of you that I've talked to, when you approach the systems, when you use that approach to study, I want you to think about, okay, assessment, what do I need to look for? What do I need to do as far as nursing implications? What do I need to do to medically treat them? And then what I want to teach the parents to send them home. Okay, so with that focus, look through your care plan. Y'all have a good day.